Hello, I'm Dr. Ken Landau. Thanks for watching. Let's talk about peptic ulcer disease. That means stomach or gastric ulcers and duodenal ulcers. Traditionally, the thought's always been too much acid, something wrong with the diet, too much stress. That's the way we thought up until the late 1970s. Treatment was antacids and medicines called anticholinergics to make the acid production decrease, surgery. Then two major events, 1976, the histamine 2 blockers like Tagamet and Axid and Pepsid. 1988, the proton pump inhibitors came out, first the Prilosec, then the Prevacid, then the Protonex. But the real major advance was in 1982 when a bacteria was discovered, the bacteria Helicobacter pylori, also called just simply H. pylori. And that changed the course of history because now it's thought that overwhelmingly the majority of peptic ulcers, stomach and duodenal, they're caused by either infection with the Helicobacter pylori or taking too much aspirin, non-steroidal anti-inflammatory drugs, ibuprofen, naproxen, or a combination of the two. So now the treatment is hopefully get off the non-steroidal, and if you can't, well then take a proton pump inhibitor or something like that. And hopefully, if you have the Helicobacter pylori, we treat it with an antibiotic and it goes away and it tends not to come back. Well, the definition of an ulcer is a hole in the surface, goes to varying depths, symptoms associated with the ulcer, gastric ulcer or duodenal ulcer. It tends to be burning pain in the pit of your stomach, we call it the epigastrium. Tends to get worse if you don't eat, so if you skip a meal, tends to be worsened, tends to improve when you do consume food, tends to get better after a meal. But here's the important point, that the overwhelming majority of people who suffer from either gastric ulcers or duodenal ulcers will have no symptoms. No symptoms. So what about the symptoms that you have, those epigastric pains? Well, in the overwhelming majority of people, more than 90% of the people who have the symptoms, those epigastric pain, well, it's not due to an ulcer. It's due to a different condition that mimics an ulcer. It's called non-ulcer dyspepsia. Non-ulcer. You don't have an ulcer. You just have the indigestion or the dyspepsia. Now we call that functional dyspepsia. You can watch my show on that. So if we look at ulcers, what's more common, the duodenal ulcer or the gastric ulcer? Well, clinically, duodenal ulcer is much more common. On the other hand, autopsy series, looking at people who die from any number of reasons, not because of gastrointestinal disease, we find that the incidence is probably pretty much equal. About 4 million people develop ulcers every year, either new ulcers or recurrent ulcers. Lifetime prevalence anywhere between 6 and 15%. We look at men, about 12%, women about 10%, but the figures might actually recently be somewhat lower because of the successful eradication of Helicobacter pylori. So maybe only 5 or 6 or 7% of the population going to develop an ulcer. Highest prevalence of ulcers was in the latter part of the 1800s and the early part, mid part of the 1900s. Nowadays, there's progressively less ulceration due to the Helicobacter pylori, at least in the United States, because we successfully get rid of it and better standards of hygiene. Well, about 15,000 people are going to die every year because of peptic ulcers, and they're going to die not because of the ulcer itself, but because of some of the complications associated with the ulcer. So the pathology of the duodenal ulcer occurs typically within an inch of the end of the stomach. We call that the pylorus. So it's in the first part of the small intestine, and that first part is the duodenum. The duodenum has several different areas, but it's that first part where the ulcer tends to occur, and it tends to be about half an inch or so in diameter. That's the typical size. Likelihood of malignancy extraordinarily rare. Duodenal ulcers may be associated with an increase in production of acid, but don't necessarily have to be. There's a substantial overlap between normal people and people with duodenal ulcers. Actually, some people with duodenal ulcers seem to have a reduced amount of bicarbonate that they produce. On the other hand, gastric ulcers can be malignant. When malignancy does arise, it tends to be in the fundus or the body of the stomach. When an ulcer is discovered in the stomach, a gastric ulcer, then multiple biopsies are appropriate. Now, if we're talking about the area right around the entry into the small intestine, into the duodenum, then that's called the antrum. And if that's where we have the ulcer, it tends to be benign in the overwhelming majority of cases. Well, here's a representation. Food goes from the esophagus through the cardia of the stomach to the fundus to the body, through the antrum and into the pylorus before it goes into the duodenum. Now, the incidence of duodenal ulcers fell up until about the 1980s, 1990s. It's been relatively stable since, but during this time, the likelihood of death, likelihood of needing surgery has fallen dramatically. And as a matter of fact, if the ulcer was due to the Helicobacter pylori and the Helicobacter pylori was treated, the likelihood of recurrence is less than 1 or 2 or 3%. In the old days, prior to us being able to eradicate the Helicobacter pylori, the likelihood of recurrence of duodenal ulcers was greater than 80%. Gastric ulcers, they tend to occur later in life when people are 50 or 60 years old. They're oftentimes silent and they present with complications. So duodenal ulcers, the symptoms, when they're present, remember, most of the time they're not present, but when they are present, they tend to occur somewhere between maybe about an hour and a half, 3 hours after a meal. They are relieved by eating or by taking an antacid. One of the characteristic types of pain associated with duodenal ulcer, it wakes you up in the middle of the night. Wakes up sometime between midnight and 3 a.m. That's the most typical symptom suggestive of duodenal ulcers, but only occurs in about 2/3 of the time when you have symptoms. And in a significant number of people, it could be just that non-ulcer dyspepsia, that functional dyspepsia. And if you happen to be older, over age 65, chances are you're not going to have any pain, but you're going to present with complications. So if you have a gastric ulcer, well, most of the people are going to present with complications. Complications like nausea or vomiting because there's obstruction, the food can't get into the duodenum because of some swelling. Or maybe there's perforation or penetration of the ulcer. All of a sudden your symptoms seem to get markedly worse quite quickly. Or maybe the pain actually is now going to be increased with the medicines. Or some people present with vomiting blood or having black tarry stools because the blood is partially digested as it passes through the intestinal system. And if a person has the typical symptoms of ulcer and has endoscopy, where they slip the tube down through your esophagus and look around your stomach and the duodenum, well, find that fewer than 1 in 3 people actually has an ulcer. Well, why did the people have the pain in the first place? We actually don't know. It's some chemical sensitivity or a chemical receptor, or maybe it has to do with some of the bile acids or the pepsin or something else, or maybe it has to do with altered gastric motility. Just don't know why people have the pain. But if we look at gastric ulcers, what about the acid? We said that in the duodenal ulcers, they might have a little bit more acid than normal. In gastric ulcers, actually, they have less acid than normal. Remember we said that the Helicobacter causes a gastritis? Well, when you get the gastritis, especially a pangastritis through the entire stomach, it turns off all the ability to produce acid. So these people are not producing significant amount of acid. The only people who do produce significant amount of acid, and in those people it's questionable, are the people who have the duodenal ulcer. Well, the symptoms, as I mentioned, elderly people don't have any symptom. If you do have symptoms, it's going to be that epigastric pain, early satiety, you're full early on. Well, abdominal pain is a poor predictor of whether you have an ulcer. And as a matter of fact, if you're taking aspirin, and you're chronically taking aspirin or a non-steroidal anti-inflammatory drug, chances are the first manifestation you're going to have is a complication. You're going to have either bleeding or perforation or an obstruction. You're not going to have any pain. So the epigastric pain that is associated with ulcers, peptic ulcers, tends to be ill-defined, and it's more aching, and it's more hunger pain, and it's sometimes burning or gnawing discomfort. Physical examination, when we examine a person, can't tell anything unless there's been a complication. So if we look at the histology, we find the pangastritis, the entire stomach can be involved, and those are the people who have the gastric ulcers and tend to have very low level of acid, or we get the duodenal ulcers, where principally it is the antral gastritis, just right around the beginning of the duodenum. That's where we get the limited amount. Well, what about the differential? What could mimic an ulcer symptom? Well, that non-ulcer dyspepsia, functional dyspepsia that we talked about. That causes upper abdominal pain that mimics an ulcer, but there is no ulcer. That occurs in somewhere around 20 to 40% of the population. So the discomfort you have isn't a good indicator. Some people develop similar symptoms if they have gastroesophageal reflux disease or biliary colic or different kind of gastric tumors, colon tumors, chronic pancreatitis. Who should be evaluated? Well, certainly if you have something that seems to be serious, you need evaluation. So if you're bleeding, if you're vomiting blood, or if you have black tarry stools, yeah, you definitely need evaluation. Or you have anemia that can't be explained otherwise, or recurrent vomiting, or you're losing weight, or you're not having any appetite, yeah, you need evaluation. What kind of evaluation? Could have an upper GI series. That's where you swallow the barium. That's still a pretty good test, and it still can tell whether you have an ulcer, but it has a hard time detecting ulcers if they're less than about 1/4 of an inch. Endoscopy, on the other hand, where a tube is passed through the mouth, through the esophagus, down into the stomach, looks around. Well, that's a really good test, and that seems to be very quick, and that's a study that's done probably preferentially right now. Well, that should be done especially if you're over age 60 and if you have some kind of complicating situation, like you're full early, or you're bleeding, you're iron deficient, or you're vomiting. And another study that should be done is a test to see if you're infected with Helicobacter pylori. That test can be a breath test, or it could be a stool test. There is a blood test that's available, but the blood test doesn't allow us to follow you after therapy. The breath test and the stool test do. Now, there are some people who are not infected with Helicobacter pylori and who don't have an excess amount of aspirin or aspirin-like substances. Those people tend to be older, and they're cigarette smokers, and they're drinkers, alcohol drinkers. The people tend to be obese and have diabetes. They have chronic lung disease, or they're African American. They're under a lot of stress. Stress, we know, can cause ulcers. We actually have the great earthquake in Japan in 2011, where people soon thereafter presented with multiple hemorrhagic ulcers. We know that refugee centers associated with stress, a lot of ulcers. We know the Danish study of people, irrespective of the presence of Helicobacter pylori, psychological stress seemed to cause the ulcers, but the overwhelming majority of people, it's either going to be Helicobacter pylori, actually anywhere between 30 and 60% of gastric ulcers caused by Helicobacter pylori, and 50 to 70% of people with duodenal ulcers caused by Helicobacter pylori. Causes equally elevated in people who are infected, people who take aspirin, and if you combine the two together, you have Helicobacter pylori and you take aspirin or the non-steroidals, you're really at very high risk. Now, if we talk about the non-steroidals, there are 300 billion over-the-counter tablets produced every year, and that's in addition to about 100 million prescriptions for the non-steroidals. So if you take aspirin, your risk is increased by about 2-fold. If you take non-steroidal, increase in risk is about 4-fold. The initial manifestation of your ulcer often is complications, bleeding or perforation. But we know that about 15–30% of the people who take aspirin or the nonsteroidals on a chronic basis will develop ulcers, but they're not going to have symptoms. It's only the 1.5–2% who start off with the bleeding or the perforation or something of that nature. What's the risk? Well, the older you are, the history of ulcer, if you're taking steroids or if you're taking SSRI like Prozac or one of those drugs, seems to increase your risk. Same thing if you're taking an angiotensin receptor blocker like Diovan, one of those kind of drugs, to treat your high blood pressure, or if you're taking multiple different types of nonsteroidals, like you're taking a baby aspirin to prevent the heart attack, and then you're taking the ibuprofen or the naproxen, that puts you at very high risk. You're taking an anticoagulant, taking warfarin, or you're taking a drug like that. That's going to increase your risk. Same thing if you're taking clopidogrel, or you're a cigarette smoker, you're alcohol consumer, and people who are co-infected with Helicobacter pylori. They're at high risk. Well, the reason that aspirin causes the problem is it causes a decrease in the production of prostaglandins, and the prostaglandins help produce the mucus and help increase the blood flow to the intestines and help do a lot of things that are beneficial. And it's not that the aspirin or the nonsteroidal sits in the stomach. Now, it gets absorbed, and that's when it does its work. Now, if you have to continue taking the aspirin or nonsteroidal because of your rheumatoid arthritis or some other reason, then you probably are going to need, depending on the circumstances, maybe one of those histamine 2 blockers, or you're going to have to continue taking a proton pump inhibitor or misoprostol or some other kind of medicine so you don't have recurrent ulcer. But the best thing to do is to get off the aspirin or nonsteroidal, if you can do it. Now, Helicobacter pylori, on the other hand, that lives in the mucus layer of the stomach. It doesn't live in the duodenum. It lives in the stomach. Even though it can cause duodenal ulcer, it still is in the stomach. And it's somewhere in the mucus layer, and it could be sitting even right on top of the epithelial cells, but it doesn't invade. There are two forms of the Helicobacter. There's one that looks like a rod, and there's one that looks like a little circle. The circle is the dormant phase. It can spread from person to person, oral to oral, or oral fecal. Well, once you are infected, you will develop a chronic active gastritis. May or may not cause an ulcer, but you will have a chronic active gastritis that puts you at risk. The prevalence of Helicobacter pylori, if we look at people less than age 30, somewhere around 20% or less. If we look at people who are over age 60, it's around 50%. Well, it's important to realize that Helicobacter pylori may interfere with the production of acid. So remember that the overwhelming majority of people who are going to develop a gastric ulcer are going to develop the ulcer in the absence of excessive acid, and actually maybe a reduced amount of acid. The likelihood of infection, well, it's increased in lower socioeconomic groups where there's domestic crowding, if there's unsanitary living conditions, if there's unclean food or water. And it seems African Americans, Hispanics have about twice the incidence as the Caucasian population. We've known about Helicobacter pylori, as I said, only since the 1980s, but the organism's been around. It was thought to have evolved somewhere around 60,000 years ago. Didn't seem to cause ulcers up until relatively recently. So ulcers have only been around for about 100 years or thereabout, because everybody was affected as a young individual, because they didn't have the sanitation, they didn't have the hygiene, they didn't have the clean water. All of that allowed people to get a little bit older before they were infected. And it's those people who are a little bit older who are infected where there seems to be a problem. Now, how do we get rid of the Helicobacter pylori? It's a combination of the proton pump inhibitors that increases the pH, and then the antibiotic that kills the organism. So usually it's a combination of 2 or 3 antibiotics. And then we do a test. We do a test to make sure you have the Helicobacter pylori. And the test can be the breath test or the fecal antigen test, or initially we could do a blood test. And if we're doing biopsies, we can test for a substance known as urease. It's made by the bacteria. It's not made by the humans. Well, after 7 or 10 or 14 days worth of therapy, for the most part, we get rid of the organism and you're not going to be reinfected. But if we get rid of the organism, that's a good idea because it prevents you getting a gastric ulcer, peptic ulcer. It prevents the duodenal ulcers and it prevents gastric cancer, but it increases your likelihood of having gastroesophageal reflux disease and Barrett's esophagus and obesity and maybe celiac disease. Used to be that the primary treatment was antacids, but now we can say for the overwhelming majority of people, antacids are not going to be the treatment. Now, some people develop the ulcer and don't have the aspirin and don't have the Helicobacter pylori as cause. And remember, those are the people who tend to smoke cigarettes or maybe have a genetic predisposition or maybe have stress. More than 90% of the people going to heal with the standard therapy, the conventional therapy. They're considered refractory gastric ulcers if they don't heal after about 12 weeks, duodenal ulcer if they don't heal after about 8 weeks. The reason they don't seem to get better is because, well, maybe you're not really taking the medicine the way you were supposed to take the medicine. Maybe the Helicobacter is persistent, or maybe you're continuing on with the non-steroidal anti-inflammatories, or maybe you continue smoking. But even so, if we double the amount of proton pump inhibitor and continue you on for another couple weeks, then most people after an additional 8 weeks are going to heal. Now we have some complications. We have to deal with complications. Complications are bleeding. That occurs in a significant number of people. Actually, somewhere between 60,000 and 120,000 people are going to be admitted to the hospital every year because of bleeding gastric or duodenal ulcers with a death rate of about 15,000. And there's no correlation with dyspepsia. Remember that. If you happen to be taking aspirin, more than 80% of the time, the presenting symptom is going to be the complication, the bleeding. And no amount of aspirin is safe, not even the 75 milligrams that you take a day. And worst thing you can do is combine the aspirin with another non-steroidal anti-inflammatory drug. That drives the intestinal tract nuts. Well, another common complication is perforation, where the hole goes all the way through. That's associated with 30-day mortality in the old days of more than 70%, nowadays still around 5 or 10%. Most of the time, the explanation for the perforation is a non-steroidal anti-inflammatory drug that you're taking for your arthritis perforates a gastric ulcer. Sometimes the duodenal ulcers can perforate. Those tend to be due to the non-steroidal anti-inflammatories, and they tend to be in the elderly population. And sometimes the ulcer can not only perforate, but actually penetrate into an adjacent organ, maybe the pancreas or the liver. And another complication is obstruction. So especially in the area where the antrum and pylorus are, you can get so much edema and so much swelling that temporarily the food can't get through. And if food can't get through, you're stuffed with just a little bit of food, you have some nausea and you're vomiting, and you have some postprandial abdominal pain, you start losing weight. Well, oftentimes in that pre-pyloric area, that's where we find the swelling, and in most people, that can heal without surgery. We just decompress the area, and if you need something more, then once healing occurs, if there's some scar tissue, that can be treated with a balloon that can be inserted and pushed out, or sometimes surgery is necessary. Now, some people are going to need those histamine 2 receptor antagonists, the medicine like the Tagamet, the Axid, and the Pepsid, and the Zantac. Going to need those medicines because they have to continue taking the non-steroidal anti-inflammatory drug. Or you need the proton pump inhibitor, or you need the misoprostol. But the good news is that now that we know that Helicobacter pylori is associated with a lot of these ulcers, it's possible that we're going to be able to develop a vaccine against the Helicobacter. And indeed, they have developed one in China, and it's fairly effective. It's effective in about 70% of the people. But the important part to realize is if you've been treated and you don't get better, and it's not associated with Helicobacter pylori, and it's not associated with aspirin or the non-steroidals, then there's no evidence that suppressing acid is going to improve the situation. Maybe the situation actually is due to ischemia, a lack of good blood circulation, or maybe you're using crack cocaine, or maybe you have a lymphoma, tumor of the lymph cells. Maybe you have infection with a virus known as cytomegalovirus, or you have Crohn's disease, or amyloidosis, or sarcoidosis, or tuberculosis. Well, in the old days, surgery used to be performed. Now, there's been a decrease of over 90% in the number of surgeries that are performed over the period of the past 30, 40 years. For the overwhelming majority of people, even if you have the hemorrhage, it's going to heal without the need for surgery. But some people still going to need surgery. And fortunately, the incidence is markedly reduced and our techniques are significantly better. So basically that's the story of peptic ulcers. Fewer now than 30 to 50 years ago, most often due to either aspirin or non-steroidals like ibuprofen, naproxen, or they're due to an infection with Helicobacter pylori, or a combination of the two. Stress can play a role, very minimal role. Most of the ulcers are asymptomatic. And if you have a symptom, chances are you have non-ulcer dyspepsia or functional dyspepsia. And for the most part, if you have the ulcer due to Helicobacter pylori, well, combination of a couple antibiotics and a proton pump inhibitor taken for a period of up to about 2 weeks, chances are going to alleviate the problem if it's due to a non-steroidal anti-inflammatory drug. Hopefully you can stop it. Otherwise, you need to take some PPI, proton pump inhibitor, or you need to take a histamine 2 blocker. And if neither of those work, then for sure you need further investigation. Anyway, thanks for watching. If you enjoyed the show, please tell a friend. Consider subscribing so you're going to be notified as we post new videos. I appreciate your interest. I'm Dr. Ken Landau.